Hi, I'm a professor at MIT and I lead the clinical machine learning group. Today's talk is joint work with Suraj Bhuminathan, Michael Oberst, Helen Zhao, and our clinical collaborator, Sanjat Kanjalal. When clinicians typically have to decide on a treatment, they take into consideration their discussions with the patient and all of the data they have on the patient, past medical records, laboratory results, and so on, and choose an appropriate treatment. For example, in this case, the clinician might choose treatment B. Today's talk will be about using machine learning to try to guide that treatment suggestion. Machine learning algorithms will also take into account all of the patient's medical records and information about the current clinical situation and will recommend a treatment. In this case, the treatment recommended is treatment C. We'll give a case study of using machine learning to guide antibiotic treatment suggestions for uncomplicated urinary tract infection. And we'll use this case study to talk about, number one, how do we learn a policy? We'll give an algorithm that can directly learn these policies from data. Number two, we'll think through how can we trade off multiple competing goals, for example, cost and effectiveness. We'll show how to learn using multi-objective. Third, we'll think about how does one properly evaluate algorithms for learning treatment suggestions. We'll introduce the concept of the target deployment. And finally, we'll talk about how one can simplify the deployment of such algorithms using a method called policy distillation. We'll close the talk by going over some mistakes that we have made in our own research with the hope that we can provide lessons that we've learned that will help the machine learning and healthcare community advance in the future. So to begin, let's talk about our application. Urinary tract infections affect 1 in 2 women in their lifetime, and it's the third most common cause for antibiotic treatments. Typically, when a woman has a urinary tract infection, a sample is provided. That sample then is sent to a laboratory where an antibiotic susceptibility profile is performed, which tests a number of different antibiotics to see whether each of those antibiotics results in resistance or susceptibility to the bacteria, which is in the sample. Unfortunately, however, these tests can take several days to a week to return. And so although having that information would be very useful for guiding which antibiotic to prescribe, in empiric antibiotic treatment, the decision has to be made at the point of care, even before that antibiotic susceptibility profile is returned. Now, we've chosen this problem for a couple of reasons. First, because of the wide prevalence of urinary tract infections, but second, because from a machine learning perspective, the learning problem is particularly easy. Typically, when we think about using machine learning for treatment recommendation, we have to tackle a difficult causal inference problem because we have to infer what would have been the causal effect of giving a treatment to a patient in some circumstance, inferring the counterfactuals of what would have happened had they gotten different treatments. Here, however, because we get the antibiotic susceptibility profile, we know, up to some extent, we know what would have happened had any of the other antibiotics been prescribed to the patient. And so both the learning problem and the evaluation problem become substantially easier. We think that this will be a really good test case for thinking through next steps for what we should be doing after learning. For example, how does one do a proper retrospective evaluation? How does one think about the usability of treatment suggestions by machine learning algorithms? How do we address questions of trust and ease of deployment? So let's begin by thinking about how do we learn a policy. Individualized treatment rules are mappings from patient features to treatment decisions, and they've been widely studied in the biostatistics community. However, generally, as I mentioned earlier, one assumes only that they have access to observational data, and one needs to use causal inference techniques to learn these rules. In our case, it's going to be substantially easier. There are 2 broad types of algorithms for learning individualized treatment rules: indirect and direct methods. In indirect methods, one takes as input features about the patient, and one predicts outcomes for what would have happened if each of the different treatment options were prescribed, in particular, how effective each of these treatments might have been. One then takes these predictions of effectiveness and combines them in some way to obtain a treatment decision. For example, here, where we're talking about 4 different antibiotics, one might choose the lowest spectrum susceptible antibiotic, meaning the one which choosing one which would resolve the underlying infection. In contrast, today's talk is going to be about direct policy learning. In direct policy learning, we take as input features as before, but now we learn a policy pi, which is a mapping from those features to a treatment decision. We assume that as training data, D, we have tuples X and R, where X are the features about the patient, and the vector R consists of rewards corresponding to each action of the possible set of actions. So for example, had we had 4 different antibiotics, and had we had labels for which of those antibiotics would be successful in resolving the infection, that is to say that the bacteria is susceptible to those antibiotics, and we have labels for which of them are resistant, then we would be able to assign rewards as shown here on the right-hand side, where one prefers to give an antibiotic which the bacteria is susceptible to. The goal of direct policy learning is to maximize the expected reward. One could think about formulating the policy pi as a argmax over functions that give you the value for different treatment options A. And using that form of the policy, one can plug it into this formula for the expected reward and get that the optimization problem that we want to solve is to maximize over these functions, giving the value or score for every possible action of the expected value of the indicator of whether the corresponding action is taken. Now, unfortunately, this function is non-differentiable and it's very difficult to optimize. In our work, we showed how one could construct a convex surrogate for this problem by turning this difficult optimization task into the following using a softmax approximation to that argmax. Now, we show in our work, which has been recently published in KDD, and I'll give a citation shortly, that when these functions fa are parameterized using a log linear model, using linear models, that this new convex surrogate is both convex and it's a consistent estimator, meaning in the limit of infinite data, that this would obtain the Bayes optimal policy. Now, the key challenge, of course, is how does one choose the reward function? For many clinical scenarios, one has to trade off between a number of different competing objectives. For the problem of prescribing antibiotics, there are typically 2 main considerations. First, one wants to choose an antibiotic which is effective, meaning that we choose an antibiotic to which the infection, we want to minimize the number of antibiotics that we prescribe where the infection is resistant to those antibiotics. Second, because of a number of research results showing that prescribing antibiotics tends to lead to future resistance due to the evolution of antibiotic-resistant organisms, we also have a societal objective of trying to minimize as much as possible the amount of broad-spectrum or second-line antibiotics. So this leaves us with a conundrum. In order to be most assured of resolving this patient's infection, we would want to give them a broad-spectrum antibiotic to which very few organisms are resistant. On the other hand, we want to minimize the overall amount of broad-spectrum antibiotics. As we can view the effectiveness of any algorithm according to those 2 criteria shown in this graph on the far right-hand side here. The y-axis is the fraction of antibiotics that are prescribed, which are second line or broad spectrum. And the x-axis here shows the fraction of antibiotics that are prescribed that do not resolve the infection, meaning that they're ineffective, which we call the IAT. Our goal would be to be on the far left, bottom left corner, where we give almost no broad spectrum antibiotics and all of the antibiotics succeed at resolving infections. Now, to tackle this problem, where now there are multiple objective functions, we're going to think about our data not as having features and rewards, but we're going to break down those rewards into its constituent factors. So now we assume that our data consists of, again, those specimen features, X. We have a vector Y that tells us the treatment effectiveness, meaning does this treatment succeed at resolving the infection or not? And we have another vector C that specifies the treatment spectrum. So if C is equal to 0, it's a first-line treatment. If C is equal to 2, it's a second-line treatment. We then define the reward function to be a combination of these 2 factors, we'll parameterize that reward by a parameter omega, and the reward is then equal to omega times y of a plus 1 minus omega times 1 minus c of a, where we reward ourselves for not using second-line antibiotics. As omega increases, we result in learned policies that have lower AIT rates, but slightly more second-line treatments. And conversely, as omega decreases, we get higher IAT rates and more first-line treatments. We can relearn our policies with different choices of omega in order to get different curves, as shown in the previous slide. So the next critical question that we need to think about is, how do we do a proper evaluation? Now, this is challenging, of course, because we would like to be able to use retrospective data, but yet we would like to have confidence that if we were to apply our new treatment suggestions in clinical practice, that it's actually going to perform well relative to either clinical guidelines or to current clinical practice. So to do this, we introduce the concept of a target deployment. This draws inspiration from recent work on emulating target trials in causal inference from observational data, work that's been pioneered by Miguel Hernan and Jamie Robbins. And the key to the target trials is to have clearly defined eligibility criteria, treatments, and outcomes, and to really put oneself in either the setting of a randomized controlled trial that one would have liked to have performed, or in this case here, put oneself in the setting of an actual clinical scenario that you plan to evaluate this method in, were you to do a prospective evaluation. One key property of this target deployment is that the treatment policy that we learn can't win from recommending an antibiotic that was not actually an available treatment at the point of care. In our work, we focus on uncomplicated urinary tract infections for this particular reason, because deriving from retrospective data whether particular antibiotics are suitable options or not is extremely difficult in settings of complications where you may have many fewer available options. For uncomplicated urinary tract infections, there are typically 4 antibiotics that are prescribed, which we will use as the acronyms for NIT, SXT, CIP, and LVX. Now, we're going to compare the results of our learning algorithms to clinical practice and to the current best practice for prescribing antibiotics in uncomplicated urinary tract infections that are known as the IDSA guidelines. The IDSA guidelines are shown on the left here, and they involve a number of different criteria, such as, for example, looking at population-level resistance rates. For our evaluation, which is done largely at Mass General Hospital and Brigham and Women's Hospital in Boston, the resistance prevalence to one of the antibiotics, SXT, does exceed the 20% threshold in that recommendation. And thus, this guideline reduces to something which is particularly simple. We first look, does the patient have resistance or exposure to a first-line antibiotic, NIT, in the past 90 days? And if the answer is yes, we prescribe Cipro, which is a second-line antibiotic. And if the answer is no, we prescribe NIT. The data we use for our research comes from the Partners Healthcare System. And the overall data set consists of over 300,000 unique patients who submitted a microbiology specimen to any Partners hospital from 2000 to present. But because we wanted to focus on a particular target deployment of uncomplicated urinary tract infections, we're actually going to focus on a much smaller subset of individuals corresponding to just 14,000 women who received empiric antibiotics for uncomplicated urinary tract infections. We're going to train and validate using data from 2007 to 2013. And in order to assess our ability to generalize to future data, which might have data set shift, we're going to use as test data from 2014 to 2016. The features we use are all features that could be derived automatically from the electronic medical record, including demographics, comorbidities, laboratory tests, location information of where the specimen was taken, past antibiotic usage, past resistance that have been recorded in the electronic medical record, along with population-level data that we generate by aggregating across a large number of patients, such as total antibiotic usage and colonization pressure. I'll now walk you through the results of our direct policy learning algorithm using particular choices of these omega parameters that trade off between IAT rate and second-line usage. Let's first start by looking to see how do clinicians do today. Well, clinicians have IAT rates that are quite high, well over 11%, and that use an overwhelming large fraction of second-line antibiotics, about 36%. Now, we could then look at what do the best practice guidelines do, the IDSA guidelines, and those are shown in purple here. What's really interesting about these is that just using the guidelines get substantially smaller IAT rate and almost never use second-line antibiotics. So there's an interesting question here about why do clinicians use so much second-line antibiotics when well-established guidelines in fact would use less and in fact would decrease the IAT rate? We think that the answer has to do with a risk tolerance level, where clinicians are worried about prescribing first-line antibiotics for patients who perhaps have particular comorbidities, although don't qualify as complicated, and perhaps combined with them being particularly bad at choosing among first-line antibiotics when they do use them. In these other squares, working their way upward, we do a random combination between those IDSA guidelines and clinicians so that we can think about what would the IAT rate be had we matched the second-line usage of clinicians. Now we have two other baselines. The first one corresponds to a what's called a constrained baseline, shown here in this square on the bottom right. And the second one is an unconstrained baseline shown in the top left, both of which have appeared in recent work by Yellen et al. Published in Nature Medicine in 2019, and which used an indirect method for trying to learn a policy and then trying to choose the amount of second-line antibiotics to prescribe based on matching second-line usage from clinicians. Now, our direct policy learning does substantially better. And there are two ways that we can try to quantify how much better these algorithms are. First, if we were to try to match the second-line usage between the policies learned by our direct policy learning algorithm and clinicians, which are shown here on the right, we can see that 25% fewer women get ineffective antibiotics. I'd like to also call out here that the x-axis starts at 0.05. Another way to try to interpret the results would be to look at a different choice of that trade-off omega, and to look to see, well, what would happen if we tried to match the IAT rate as close as possible between the direct policy and clinicians? That would be choosing this point in the very bottom. And there we see that we both get substantially smaller IAT rate, and we nearly eliminate second-line antibiotic usage. So this is promising, but we've got a number of factors to take into consideration before we could think about how we could actually deploy this in clinical practice. One of the first challenges is that these models, as described, use a very large number of features, in particular over 900 features. If one were to try to deploy this within commercial electronic medical record systems, it might involve a very difficult integration problem. So we then asked the following question: is it possible to somehow construct a simple treatment policy that might obtain competitive performance, but yet uses many fewer features? We do this by distilling the optimal policy, by looking deeply at the model using various machine learning introspection techniques, and really understanding how it makes its decisions. As a result of that analysis, we developed the following simple, easily deployable policy. First, we're going to use a very small linear model involving just 18 features to predict whether a patient needs second-line treatment. So at this point now, we're ignoring which of first-line or second-line treatment is needed, just seeing which of those two broad categories. Then we'll choose a threshold on that prediction, and based on that, we're going to, if we're above the threshold, we're going to predict with the following preferred order. First, we would prefer Cipro over NIT over SXT. And if we're below the threshold, meaning to say we prefer first-line treatments, then we would first start with NIT, then SXT, then CIP, Cipro. And of course, we would prefer to just choose the first one in those rankings. But the reason that we're giving a ranking here is because we're going to choose the first treatment in each of those rankings for which the patient has neither prior resistance nor prior exposure. So this is the policy, and what I haven't yet specified is how we learn that now small model F to quantify whether the patient needs second-line treatment or not. To do that, we take the original policy pi that was learned in the full feature set. Again, pi is choosing among 4 different antibiotics. And we're going to look at pi's choices just among those 2 equivalence classes of 2 different first-line antibiotics and 2 different second-line antibiotics. We learn a very heavily regularized L1 logistic regression model to try to mimic the optimal policy's first versus second-line treatment decisions. And by pumping up that regularization constant, we find a model that has just 18 features. Those 18 features that it chooses consist of prior resistance and exposure, whether the patient has recently had an E. coli infection or recently had surgery, colonization pressure over the last 90 days, the location of where the patient was receiving service, whether it was an outpatient setting or ER, and demographics. And surprisingly, we found that this simple policy, despite being relatively much easier to implement, gets equivalent to performance to that much more complex policy. So we see here that the IAT rates are basically the same between the full policy and the simple policy, and the second line usage is actually a little bit smaller on the simple policy. Now, there's one final important step that I haven't mentioned in order for us to fulfill this promise of the target deployment. And that is recognizing that some treatments might not be available to clinicians due to contraindications, such as allergies to one of the medications or a condition called pyelonephritis, which usually should be treated with second-line antibiotics. Now, these are typically recorded in clinical notes, not in structured data, making it much more difficult to identify these situations and to limit the set of actions that our algorithms get access to. We developed an NLP algorithm to extract these and then modified that simple policy that I just described to exclude these contraindicated treatments. This results in about 7% of changes to the original decisions. Now we've got ourselves in an apples-to-apples comparison where we can actually look at clinical performance versus the performance of our policies. We see that indeed the amount of second-line usage, it did increase, whereas previously it might have been closer to 0. Now the second-line usage is about half that of clinician usage, but we still see much bigger gains in the IAT rates, which have decreased. Now, in the last part of the talk, I want to talk about some mistakes that we made. To do so, let me talk first about how laboratory testing for antibiotics are done. After culturing the bacteria is put into a number of different test tubes, and an antibiotic is placed within these test tubes at varying different concentration levels, typically varying on a logarithmic scale. One then looks to see what is the minimal concentration of the antibiotic such that all of the bacteria is killed. And this is known as the minimum inhibitory concentration. Now, the choices of what levels to test have changed over the years. And so in trying to derive the labels used by our learning algorithms, we decided to convert all of these different MIC values to resistance or susceptibility labels by using the latest 2017 breakpoints. Now, when we took those labels and we used them within our learning algorithms, one of the first things we recognized when doing model introspection, and in this case we were using clinical notes as features, were that years turned out to be very predictive. Digging in a little bit further, I mean, we expected some data set shift, but not that much data set shift. And when we looked at the resistance rates across time for a variety of antibiotics, we saw a trend that looked very worrisome. So for example, here we see one of the antibiotics, and up until about 2007, nearly all of the specimens were observed by our derived labels to be resistant to this antibiotic. Thinking that this might have had to do with the choice of breakpoints, we looked at the logarithm of the MIC, or minimum inhibitory concentration levels, which was the raw data used to derive the labels. And we saw that up until 2005, the smallest values that could be observed were 2. In talking then with our clinical collaborators, we discovered that in 2006, the testing machine had changed to allow one additional row that allowed one to test for much smaller levels of concentration than ever before. And so the smallest observed log MIC decreased, which meant that previously all specimens were always above that value and thus labeled as resistance. In the second mistake, this is about a month later in our research, we noticed that there was some moderate differences in resistance rates between the training data and the testing window. We furthermore noticed that location, in particular the hospital floor, was a very predictive feature in our models, and that didn't at all align with our clinical intuition. So in further digging into it, we looked at the following antibiotic. One of the examples where we saw the resistance rates change between train and test, that split was roughly in 2013 here. And as before, we wanted to see, maybe it had to do with some of the choice of breakpoints. So let's now look at the MIC values that led to these choice of resistance labels. What we see here now, splitting the observed MIC values by institution. In cyan here are the samples coming from MGH, and red are the samples coming from Brigham and Women's Hospital, is that up until about 2015, it appears that all of the samples from Brigham and Women's Hospital have resistance rates which are substantially lower. Almost never do you observe a resistant specimen, whereas for MGH, you have a much more consistent trend. When you look at the MIC values, you have exactly the same phenomena. And then talking to our clinical collaborators and the folks who run some of these microbiology labs, we came to the following conclusion, which is that until May 2005, Brigham and Women's Hospital likely tested resistance to this combination drug, SXT-TMP, which I'm denoting just as XXT in these figures, by examining resistance to just one of those. But since just one of those drugs has a substantially smaller weight, the corresponding breakpoints would always label them as susceptible. So that led us, of course, to having all of our conclusions invalidated. Here I'm showing a picture from one of our recent laboratory meetings right after this was found, where we then subsequently had to revise all of our conclusions. Of course, this is really embarrassing, and the reason why I'm telling you about this is because I think this is just a trend of a much broader phenomena in machine learning in healthcare, where it's really easy to make mistakes in your evaluations, and until you dig really deeply into it, it might go unnoticed. After correction here, the resistance rates went up to normal, and you no longer saw this non-stationarity across time. And moreover, the area under the ROC curve for predicting that resistance to that one antibiotic, if you were to use one of the indirect methods, dropped substantially, as you might expect now without that fluke. So the lessons learned from this are, first, always look for dataset shift in your data, not just in the data, not just in the features, but also in your labels, and be very skeptical when you find it. It really helps to introspect into your models and to try to better understand the clinical motivation for why your model might be predicting one way it does, and to better understand the underlying clinical data generation process. So in conclusion, in this talk, I've given you a case study of how one can use machine learning to suggest treatments at the point of care focused on antibiotic resistance, focused on antibiotic prescribing for uncomplicated urinary tract infection, where we showed that we can substantially reduce the amount of second-line antibiotics while, in fact, reducing the amount of ineffective antibiotics that are prescribed. We introduced the concept of a target deployment to frame retrospective evaluations so that one can get a fair apples-to-apples comparison to current clinical practice, even before one does a prospective evaluation. We showed algorithms for how to efficiently learn optimal treatment policies in multi-objective settings. And we then showed how one could distill these policies into simpler policies that might be more easily implemented in commercial electronic medical record systems. Finally, we showed how mistakes in retrospective evaluations are commonplace, not exceptional, and we strongly suggest that the community makes standard practice both dataset shift checks and the use of model introspection as tools for developing safe and robust machine learning in healthcare. As a final comment, the data set which we used is going to be publicly released, and we encourage folks to download it and use it in their own research. Thanks.